This is PANRE Review, Gastrointestinal System, Part 2. My goal with this is to be short, succinct, simple, and relevant. So with that, let's move on ahead. If a patient presented with extreme epigastric pain, what diagnosis would you be thinking of? Very severe or extreme epigastric pain may make you think of pancreatitis. What are some of the risk factors or causes for pancreatitis? One of the main ones is alcohol. Another common cause of pancreatitis is going to be a secondary thing to problems in the biliary tract. It can be drug-induced, it can be due to trauma, AIDS, or vasculitis, but the primary two are alcohol and biliary tract problems. What are the signs and symptoms? As mentioned earlier, it is severe abdominal pain, very often felt in the epigastric central area, very intense. Sometimes the individual may have jaundice. Remember that 40% of the time there are biliary tract issues, and so jaundice may be present. Usually there is nausea and vomiting. Fever is in 76% and guarding in 68%. A few signs that may show up on a test is called a colon sign. What is a colon sign? Colon sign is when there is blue around the umbilicus. What is this an indication of? A colon sign is an indicative of pancreatitis that has been necrotizing. The diagnosis is made how? If you are suspicious of pancreatitis, you'll want to run a lipase and an amylase, the more important of the two being the lipase. Now the actual diagnosis, the gold standard, is going to be made by doing what imaging test? The imaging test that will be diagnostic of acute pancreatitis is a CT scan. The CT scan can help assess the damage as well to see if there is any necrotization that has occurred. How do we treat pancreatitis? Well, the first and most important thing will be NPO, and just put the patient on fluids. You don't want anything entering into the stomach that will cause a release of any of the enzymes from the pancreas that can cause further damage, so you need that rest. Antibiotics, if it is necrotizing. An antibiotic that is used in pancreatitis is imipenem. If there are problems in the biliary tract, one may need a cholecystectomy. If there's pancreatic duct disruption, similarly, surgery would be indicated. If there is an abscess due to infection, the abscess may need to be drained, and that would be a surgical procedure. So that is pancreatitis. Next, we have a patient presenting with abdominal pain. Instead of being epigastric, which makes you think of pancreatitis, this patient has abdominal pain, and it is beginning somewhat in the umbilical area. What will that make you think of? Umbilical pain may be an indication of appendicitis, especially if the pain begins in the umbilical area and begins to move into the right lower quadrant. Appendicitis is inflammation of the variform appendix. The variform appendix is found in the right lower quadrant of the abdomen. What are the main signs that we find on physical examination of appendicitis? These main signs are referred to as peritoneal signs. They include Rosving's sign, the psoas sign, heel drop. What are these three tests? Rosving's, the way that I remember that, it's a stupid mnemonic. It is if you were to push on the left side of the abdomen, they'll get pain on the right side. Pushing on the left makes the right side sing. That is Rosving's sign. A psoas sign is basically a quadriceps stretch. You're going to get them to flex at the knee and then somewhat extend at the hip, I believe, like you would in a calf, or not a calf, a quadriceps stretch. And that is if they're getting pain in the and they're getting some extensive pain from that, then that would be a peritoneal sign. Another one is the heel drop. I like the heel drop, and it's something that often presents in the history when they're moving in a car. Those little bumps in the car are causing them some pretty significant pain. A heel drop, you get them to go up on their toes, and then they'll drop abruptly, if they'll be willing to do that, and then they get some pretty significant pain. Those are signs of appendicitis. Vomiting can be included, but it's not 100% of the time in appendicitis. Vomiting following pain. Most of the time, if ever there is that lower abdominal pain, you may be suspicious of appendicitis. Anything from the umbilicus downward may make you suspicious. So you'll probably want to start by doing a CBC. Most of the time, there is a increase in the white blood cell count, greater than 10. It was noted that this is found in 80 to 85% of adults with appendicitis. What is the primary diagnostic tool that we use for appendicitis to be complete in ruling out appendicitis? That would be a CT scan with contrast. CT scan with contrast is diagnostic of appendicitis. The definitive treatment is generally a appendectomy, which is a surgical procedure. If I recall, in Europe, in some situations, they are treating it with IV antibiotics, but that is not the standard treatment as of yet in America. So appendicitis, anytime you have pain in the just lower of the umbilicus, you may be suspicious of this. If you're in a gray area, which a lot of times you are, get a CBC, do that workup, see if you get increased white blood cell count. Sometimes you may observe and have the patient come back the next day, and you can repeat that to see if the white blood cell count has increased, and then inform them about some of the signs of worsening symptoms. If at any time they're getting worse and worse and worse, have them go to the emergency room where they can get a CT scan, which would be diagnostic and can at least rule it out. There is a different type of appendicitis. At least I want you to think of it like an appendicitis because it is actually very similar. So this would be generally presenting as, instead of on the right lower quadrant, you're going to have left lower quadrant pain. Left lower quadrant pain should make you think of what? The diagnosis that you should think of is diverticulitis. Diverticula is an outpouching in the large intestines, usually in the descending or sigmoid colon. If you think about what the appendix is, the variform appendix is somewhat like an outpouching as well. So they present with very similar symptoms. The location, though, is different. Diverticula, this outpouching in the large intestines, can either be a diverticulosis, which usually is not causing many symptoms, or a diverticulitis, which is very similar to appendicitis, and an inflammation of a diverticula. The main symptoms being lower left quadrant pain, that abdominal pain, and fever. Sometimes they may even have peritoneal signs. Generally, a diverticulosis is asymptomatic. That is problematic for diagnostic reasons because how do you ever diagnose that? Generally, things that are asymptomatic are found incidentally. So diverticulosis may be found when you are doing a CT scan for workup of a different condition, or diverticulosis may be diagnosed in something like a colonoscopy. What group of people is most What group of people is at highest risk for diverticulosis or diverticulitis? It generally occurs in elderly people, about the greater than age of 50 and up. The risk will increase with age. What would be one of the major risk factors that you'd be concerned about? The major risk factor that you can see with diverticulitis would be a perforation. And signs of a perforated bowel would be what? Absent bowel sounds. I believe also free air under the diaphragm on an x-ray would be indicative of a perforation. How would you do the workup? The workup may include a CBC and a CMP. What would you see on a CBC though? Similar to a appendicitis, you may see leukocytosis. CT scan is diagnostic as well. So just to test your memory, the diagnosis of pancreatitis is made through what imaging? That is a CT scan. The same would be of what we just mentioned, diverticulitis, a CT scan. Why are these different than an appendicitis? Because an appendicitis is diagnosed using a CT scan with contrast, whereas diverticulitis and pancreatitis do not have contrast used in the diagnosis. Right upper quadrant abdominal pain. Right upper quadrant abdominal pain usually makes you start to consider some sort of disorder in the bile duct or the gallbladder. So there are two diagnoses that are covered in this. They would be cholangitis and cholelithiasis. Cholangitis, itis meaning inflammation, this is inflammation of the bile duct. It's generally caused due to poor drainage of the bile duct, which then gets infected. What are some of the bacteria that would infect the bile duct? The bacteria would be E. coli, that's about 27% of the time, Klebsiella, 16% of the time, Enterococcus, and Streptococcus. What are the signs and symptoms of cholangitis? There is something you want to remember specifically associated with cholangitis. It is known as Charcot's triad. Charcot's triad is what three symptoms? The three symptoms, if you recall, because this is the bile duct, one of them involves right upper quadrant pain. The other two would be fever and jaundice. Right upper quadrant pain, fever, and jaundice. Some of the other signs and symptoms associated with cholangitis would be clay-colored stools, fever and chills, lethargy, with that emphasis on the right upper quadrant pain. They may even present similarly to cholelithiasis and have a Murphy sign. What is a Murphy sign? Murphy sign is the patient will inhale, and as they're exhaling, you're going to push even deeper into the right upper quadrant. A lot of the times that may cause them to gasp a little bit or have this increased pain or breathe back inward. That is a Murphy sign. What is the diagnostic tool that we use for cholangitis? The best way to look at the gallbladder is not necessarily with a CT scan, rather it would be with an ultrasound. And even another way of getting a look at the gallbladder would be what? Other than an ultrasound, an ERCP may be used. I believe that stands for endoscopic retrograde cholangiopancreatography. That is ERCP. A lot of the times, because of the location, what's important to include in the workup in a clinical setting, because it's still upper quadrant pain and it's right upper quadrant, it may be close enough to the pancreas that you'll likely want to run a lipase and an amylase as well. Get a CBC and a CMP. The CBC will be helpful to see if there is a leukocytosis that can be a sign of an infection. How do you treat cholangitis? Obviously, you have your ABCs. Make sure the patient is stable. NPO, because you don't want to put anything in the stomach that's going to aggravate these organs that are used in digestion. So NPO, antibiotics is used. They may need a surgical cholecystectomy. That will be decided after this has been diagnosed in the ER and a surgeon or a specialist has made that call whether they need surgery or not. But because there is this inflammation and this inflammation is due to a bacterial infection, they will need antibiotics. Gallstones, on the other hand, cholelithiasis, can also present with Charcot's triad. Charcot's triad, if you recall, is what 3 symptoms? Right upper quadrant pain, jaundice, and fever. That would be an indication that they have not just cholelithiasis, but they have cholangitis. The main differentiation is going to be found by doing what? On your diagnostics, when you're doing an ultrasound, they will be able to see if there are gallstones or if there are no gallstones. If there are not gallstones, then obviously they do not have cholelithiasis. If there are gallstones and Charcot's triad, then they have both the diagnosis of cholelithiasis and cholangitis. The cholelithiasis generally perceived to be the cause of that. Because of the obstruction caused by the gallstones, it caused the bile duct to drain inappropriately, and as a result, it got infected. What are the main risk factors associated with cholelithiasis? These risk factors are the F's: 40, fat, fatty foods, and fertile. I suppose you could also add in there familial history would be another risk factor of cholelithiasis. Signs and symptoms. A lot of times gallstones may actually be asymptomatic. If that's the case, they would only be found in a medical setting through an incidental finding. Most of the time, the patient is presenting because they have pain, abdominal pain. That pain may be mostly felt in the right upper quadrant. It may have biliary colic. What is biliary colic? Biliary colic is 30 to 90 minutes of pain. It's pain that usually resolves within 30 to 90 minutes. It tends to be aggravated with food. In fact, that is one of the signs. That is called Collins sign. Collins, Collins, because Collins sign was what, if you recall? Collins sign was basically this bruising around the umbilicus, which is a sign of necrotizing pancreatitis, whereas Collins sign is the pain is aggravated by fatty foods. The pain may be referred into the shoulder, and the individual may also have nausea and vomiting. Those are the signs and symptoms of gallstone. Remember the workup. Because this is in the upper quadrant of the abdomen, you're going to want to rule out a pancreatitis as well. So a lipase and an amylase may also be run with a CBC and a CMP. The diagnostic gold standard is going to be an ultrasound. An individual may get an endoscopic retrograde cholangiopancreatography because sometimes the gallstones, the problems in the gallbladder in general, which are not listed in cholelithiasis as well as cholangitis, but someone may have these chronic gallbladder symptoms. So you do these tests and you find out that okay, that doesn't look like there's anything wrong with your gallbladder. Then sometimes, because it's chronic and they're safe, they're not looking very toxic, they go home, but they just continue to have this chronic nausea and vomiting and pain that comes and goes. You may get a HIDA scan, and the HIDA scan can be useful to see if there is a problem in the gallbladder with its drainage. It's going to be evaluating a little bit more of the functionality of the gallbladder. And then if you're still suspicious, the individual may get an endoscopic retrograde cholangiopancreatography to be more definitive. What is the treatment of cholelithiasis? If it's asymptomatic, then observation. If there are gallbladders that are if there are gallstones that are obstructing the gallbladder, that is, then the individual may get a treatment called lithotripsy to break up the stone, or they may just remove the gallbladder wholly, which is a cholecystectomy. An individual presents with the complaint of abdominal pain. The abdominal pain is severe, very severe. The individual was given opioids, and that didn't even seem to control the pain. You did a physical exam, and you didn't find much. Maybe they just had some general tenderness everywhere, or severe tenderness everywhere, and this pain is just severe. Diffuse abdominal pain that is moderate to severe. Oftentimes, the individual does not want to eat, anorexia, nausea and vomiting, and diarrhea. You would be considering a ischemic bowel. Ischemic bowel generally occurs in the mesenteric vessels. How is this diagnosis made? The diagnosis is made with a CT angiogram. So if you remember, if you're thinking of pancreatitis, that is a CT scan. Diverticulitis is a CT scan. If you're thinking appendicitis, it would be a CT scan with contrast. Whereas if you were considering ischemic bowel, it would be a CT angiogram. Remember, the physical exam is generally benign. However, the patient has pain that are greatly exaggerated depending to what you are seeing on the physical exam. One of the things that you may run as well is you may run an X-ray prior to doing the CT scan. There is a common finding that is seen on an X-ray. This buzzword associated with ischemic bowel and X-ray is thumbprinting of the bowel. Thumbprinting of the bowel is indicative of ischemic bowel. What are the risk factors? Generally, ischemic bowel is a consequence of clots in the heart, myocardial infarction, coronary artery disease, valvular disease, arrhythmias. One random risk is also delete one random risk. The risk is going to be atherosclerosis. So a clot can then spread somewhere. It's most often a clot in the heart that is moved and now is obstructing one of the mesenteric vessels and causing ischemic bowel disease. Other risk factors, at least who this generally affects, is going to be the elderly. There are different phases. A hyperactive phase, it's usually that severe abdominal pain and bloody stools. A paralytic phase, where there's more pain, lots of tenderness, and this finding, absent bowel sounds in the paralytic phase. The shock phase, fluids leak through the colon and result in shock, acidosis, and dehydration. That individual would be severely, severely toxic. The signs and symptoms, as mentioned before, abdominal pain, 78%, bleeding, 62%, diarrhea, 38%. Remember, thumbprinting on the X-ray. Other labs that are sometimes helpful would be a APTT and a prothrombin. If you're doing a CBC and a CMP, you'll be looking for that acidosis and that toxic effect. What is the treatment? The treatment is generally surgery, thrombolytics, piperine. Remember as well with this that there is IV fluids, bowel rest, NG tube, and antibiotics may be considered because if there has been any damage and death of the cells, there can be risk of infection. What is cirrhosis? Cirrhosis is the fibrosis of the liver. Think of it as a process as the more damage that is done to the liver, the more that there is scarring. Just like you think of scar tissue forming in areas where there is damage, cirrhosis is similar. Think of it as the scarring of the liver. Fibrosis of the liver that converts normal cells with abnormal cells. It is the 12th leading cause of death. The risks for cirrhosis would be hepatitis, about hepatitis C in particular, 26%, hepatitis B, about 15%. What is one of the things you want to remember with hepatitis B? Hepatitis B usually does not come by itself, but it is a co-infection with D. Alcohol would be about 21% of cases, hepatitis C about 15%, and unknown about 18%. So obviously, the two things you want to associate with cirrhosis are going to be hepatitis and alcohol. What are the signs and symptoms of cirrhosis? Most of the time, it is asymptomatic. The cirrhosis is discovered through some sort of routine screening if the individual has significant risk factors or has been diagnosed with hepatitis when you're evaluating the health of one's liver. It may be found because you have been doing routine screening with a CBC and a CMP, and on the CMP, you've been checking the LFTs. As those LFTs increase, you decide to look at the liver and assess it, and that is done with an ultrasound, and that's how you are able to identify that there is cirrhosis. Often signs and symptoms could be, if it's severe, you can detect hepatomegaly, abdominal pain. In the most significant cases of cirrhosis, what finding would you see? The most significant cases of cirrhosis will cause ascites, which is fluid in the abdomen. It can think of it kind of like edema, abdominal swelling. Now, the ascites, having that fluid, can be benign unless it gets infected. It puts people at risk for infection. If the ascites is infected, it's going to be really, really tender, and they'd have that fluid wave that causes pain. Individuals with cirrhosis, one of the signs may be jaundice. One of the best places to detect jaundice would be where? In the whites of the eyes. There is also another significant problem that is associated with cirrhosis. We mentioned ascites, but another one that is associated that you need to know is esophageal varices. Esophageal varices is kind of, think of it like, this is a bad image, but think of it like hemorrhoids, but of the esophagus. Because of the backup, the vessels have swollen, and what that can do is sometimes it could either cause obstruction, if it was extremely severe, it'll cause dysphagia, but it puts one at risk for significant bleeding because it's very difficult to get the bleeding to stop in the esophagus, and so that is a very significant and sometimes an emergent condition. Hepatic encephalopathy is another one that can occur. Hepatic encephalopathy will cause portal hypertension. What is the diagnosis? How is the diagnosis made? It is done primarily through an ultrasound. A lot of the times, though, if you find cirrhosis, you'll be considering doing a pretty extensive workup to identify some of the causes. What is included in this workup? So this is a moment that you need to take a second and think through what labs you would run when you're evaluating cirrhosis of the liver. Labs that are run include CBC, CMP. The CMP will tell you the AST, the ALT, and the GGT. The more obscure ones that are run would be ceruloplasmin. What is a ceruloplasmin level looking at? Ceruloplasmin is looking for Wilson's disease. Alpha-fetoprotein. Why would you run an alpha-fetoprotein? This could be a sign of a carcinoma. Now, you also want to run your hepatitis labs, and those would be the hepatitis serum labs, so you can evaluate if there is hepatitis A, B, C, or D. Also, you may want to consider running an ANA. An ANA would be able to detect if there is an autoimmune source of the cirrhosis. What are the treatments? Liver transplant if the cirrhosis was extremely severe and the person needed it in order to survive. If it was an autoimmune hepatitis, then prednisone could treat it. If it was Wilson's disease, which remember that was detected with a ceruloplasmin level, Wilson's disease is treated with zinc and trintine is what I wrote. I may have that wrong. Trientine. Trintine, zinc plus trintine. If an individual had hemochromatosis, you would need to they would be treated with a phlebotomy, and hepatitis B and hepatitis C is treated with interferon. The treatment of Wilson's disease is trientine. I did have that right. Another one that I was more familiar with from my schooling was penicillamine. It can treat too much copper in the body. One of the other things that we mentioned was a disorder that can cause cirrhosis, but we did not discuss any labs that were associated with that. So I want you to think of a ferritin level, serum ferritin, as well as running a transferrin saturation. So serum ferritin levels that are higher than 200 mcg per liter, so very high serum ferritin levels, as well as a transferrin saturation, may be indicative of what disorder? That disorder is hemochromatosis. Hemochromatosis can cause cirrhosis, and the treatment of hemochromatosis would be phlebotomy. Moving on, we have acute hepatitis. Acute hepatitis, there are different types of hepatitis. Acute hepatitis, what are the symptoms that you would see with hepatitis? Jaundice, ascites, cerebral edema in the most significant cases that would be causing cognitive changes, right upper quadrant tenderness, nausea and vomiting, and hematemesis. So the individual will usually have that right upper quadrant pain because there's inflammation of the liver, because the liver is significant in digestion, the individual will have nausea and vomiting, and they may even be throwing up blood. Because of the hepatitis affecting the liver's function, there can be a backup which is causing jaundice. The individual, in the most severe cases, will start to have fluid buildup in the abdomen due to the level of cirrhosis and inflammation, and that would be ascites. And again, that very significant finding would be, or at least finding that would be very down the road that could be significant, would be cerebral edema. Acute hepatitis, the workup is usually, the most significant workup component would be hepatitis viral serology. In that, it'll be assessing for hepatitis A, B, C, and D. You also want to run what tests? ANA, CMP, an ultrasound of the liver. You can get an acetaminophen level if you think that this could be caused by toxicity from acetaminophen. Ceruloplasmin levels would be looking at Wilson's disease. And as we just mentioned, you may want to get a ferritin level. A serum ferritin level and a transferrin saturation to maybe consider hemochromatosis. The treatment of acute hepatitis may depend on what is causing it. If it is due to if it's just significant hepatitis and the liver isn't functioning, then the treatment would involve a liver transplant. If it was an autoimmune disorder, then prednisone would be treating it. If it was due to Wilson's, remember zinc and trantine or penicillamine. Hemochromatosis is treated with a phlebotomy. How do you treat hepatitis? Hepatitis B and C are treated with interferon. If an individual had acetaminophen poisoning, what is the antidote to acetaminophen poisoning? That is N-acetylcysteine. If it was due to acute toxicity from alcohol, the treatment and antidote of alcohol toxicity is methanol. Hepatitis A, B, and C are the most common. Hepatitis A and E are not chronic. Hepatitis A is transmitted how? So think of this as hepatitis A has the word fecal. 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 Hepatitis A is transferred through fecal matter. Hepatitis B, what do you want to think of with B? A sexy babe. And just as a sexy babe, you want to have a relationship with them, it tends to be a co-infection. So hepatitis B and D usually come together. Sexy babe, sexy body, think of that body, sexy babe body is going to be hepatitis B. It is transferred through sex and is generally a co-infection with B. Signs and symptoms, if it's more in a chronic sense, anorexia, nausea, vomiting, fatigue. If that individual had this general level of fatigue, especially with any gastrointestinal symptoms and you're not finding it, eventually you're going to run that very common test, the CBC and the CMP, and the CMP on its liver function test is going to show some things that have gone haywire, and as a result of that, you're going to do a significant workup of the liver, which included all of those labs that we reviewed earlier. Anti-HCV indicates an acute hepatitis C infection. Anti-HBC IgM indicates recent infection. Anti-HAV IgM indicates recent infection. If you have a person test you that level of specificity, they just hate you and the world and life and should probably go see a psychiatrist. So, The treatment, hepatitis A, remember, A is that infection occurs through fecal matter, tends to be self-limited. So you would do supportive treatment. Hepatitis B Hepatitis B and C can be treated with interferon. Hepatitis C tends to be the more chronic one, and I believe there is a new medication out to treat hepatitis C. So we'll be covering a few other of these things as we look at chronic hepatitis. So chronic hepatitis is inflammation of the liver for greater than 6 weeks. The most common causes are going to be hepatitis B and C. Why not A? Because A is more short-lived and is generally causing an acute hepatitis and is self-limited. The causes of chronic hepatitis other than hepatitis C and B are what? Fatty liver, alcohol, autoimmune, Wilson's disease, hemochromatosis. Signs and symptoms of chronic hepatitis would be enlarged spleen, spider angiomas. If a person had significant hepatitis, they may have something known as a caput medusa. What is a caput medusa? That is these significant vessels that are appearing in the abdomen. They may have ascites. That ascites can either be infected or non-infected. If it is infected, it would be extreme tenderness, and you're going to need to get that drainage and antibiotics immediately. Portal hypertension, hepatic encephalopathy, esophageal varices, jaundice, nausea and vomiting, fatigue, anorexia, and malaise. In clinic, why is all of this relevant? Because when an individual presents with fatigue, you should probably run a CMP and evaluate the liver. The CBC and the CBC can see if there's an anemia, and the CMP is going to look at the liver, and the liver can cause chronic fatigue. If the individual has symptoms like chronic nausea and vomiting, make sure you run a CMP. If the individual is having chronic abdominal pain, what do you run? A CMP. That's the clinical part of this, is the patient is presenting with these things, and I think this is pretty standard that when you're doing these workups on patients, but it kind of helps connect the dots there for you. Diagnosis of chronic hepatitis. Ultrasound, obviously, is the main diagnostic feature. A biopsy may be needed to differentiate and identify the type, what's going on at the cellular level. A CMP obviously will show the liver enzymes. The hepatitis labs, ceruloplasmin, ANA, alpha-fetoprotein, and then the ferritin. The serum ferritin will also be helpful. Treatment, we've gone over the treatments depending on what the causes are, so we won't review that. AST and ALT ratios can be helpful. The AST-ALT ratio is approximately 0.8. If that ratio is 2 or higher, meaning the AST is about 2 times higher than the ALT, then that may be indicative of what? If the AST is higher than the ALT, then think of alcoholic liver disease. The only reason I remember that is if its AST is greater, we usually put that on the left, and then you can think of that as greater and first. And then you have the SALT, that spells salt. Salt is in some alcoholic beverages, and so the AST greater than ALT ratio is going to be indicative of alcoholic liver disease. However, when that ratio is not seen, that can be indicative of a non-alcoholic fatty liver disease. So that's something worth remembering as well and may show up on tests. Moving forward, we have hernias. What are hernias? Abdominal hernias can occur in many different places. Most often we think of them in the inguinal area, but they can also be umbilical and epigastric and femoral. Signs and symptoms of hernias. The patient will present with a sensation of a mass, or that there is a visible mass. Sometimes there may be some general pain if it's a very small hernia and they haven't explored the area, and they may look and they don't see anything. So it's usually, the sign and symptom is a palpable hernia on physical exam. There may be swelling. Most of the time it is painless, and it may even be reducible. If it was painful and there was this mass, then you need to be concerned about what? The concern that you would have with a hernia would be a strangulated part of the bowel. So if the hernia gets strangulated, then that is a problem. Because remember, what is the hernia in general? It's a protrusion of any viscous from its proper cavity. So it's generally going to be the intestines. Because of this outpouching, it's been able to protrude out into a different area, into either the epigastric, umbilical, inguinal, or femoral area. And as a result, you have that mass, and the mass is basically part of the bowel that you can push on. Again, that you can try and reduce them. Generally, this is treated by referring them to a surgeon or just watchful waiting. And that is a hernia. Its diagnosis is quite straightforward. When you're thinking about an inguinal hernia, one of the things that can be done is you could run an ultrasound. This is a tricky thing in clinic because if you're thinking about running an ultrasound, what are you going to do about it? If it's a hernia, then you're going to do nothing. If it's not a hernia, I guess you can rule out that it's not a hernia, so the ultrasound does have its value there. What are esophageal varices? Esophageal varices are extremely dilated submucosal veins in the lower half of the esophagus. What is it a consequence of? Esophageal varices are most often a consequence of portal hypertension, and that portal hypertension is caused by what? That would be cirrhosis of the liver, which we've already reviewed its many causes. Varices are an emergency due to the bleeding risk. Remember, the risk factors are cirrhosis and alcohol abuse. Signs and symptoms, they may have jaundice due to the liver dysfunction and liver problems, weakness, nausea and vomiting, and abdominal swelling. However, when you're thinking about the esophagus specifically, they may be vomiting large amounts of blood, and they may have melena, which would be black tarry stools. The main thing with esophageal varices, unless you found them incidentally as a workup of the, meaning you found them incidentally, you found them because, delete that part. You find esophageal varices because the patient has significant cirrhosis and you're doing it just to assess the area to make sure, to assess how much risk they are at with esophageal varices. So you may find them in that way, but if it was presenting, it would be presenting from a patient who has chronic cirrhosis and they're vomiting large amounts of blood. If an individual is vomiting large amounts of blood, you're going to be running what test? You would be running an endoscopy. And generally, the person performing the endoscopy may be prepared to treat it at the same time. They may be doing a TIPS, a portosystemic shunt. They may do some endoscopic treatment, which could be some cauterization. This individual may need a liver transplant. By the time you're getting significant portal hypertension and esophageal varices, you're at the point where your liver has failed so much that you are at high risk of passing away due to the cirrhosis and the liver damage. Mallory-Weiss tear. What is a Mallory-Weiss tear? Usually, it is a consequence of what? So the thing that we all associate with Mallory-Weiss is retching, vomiting, coughing, or straining. It's often a single tear at the esophagogastric junction. 5% of GI bleeds are a result of this. What is one of the main risk factors for a Mallory-Weiss tear? Aside from the retching, vomiting, coughing, and straining, it is alcoholism. What are the signs and symptoms of a Mallory-Weiss tear? These signs and symptoms are hematemesis that follows retching. So you want to get that sequence as when you're getting your history. You are coughing up blood or you are vomiting blood, and this occurred after significant retching, vomiting, coughing, or straining. If it's ongoing, then hospitalization for monitoring would be recommended. The diagnosis is found on esophagogastric duodenoscopy, and the treatment would be esophagogastric duodenoscopy with electrocauterization. If the bleeding stops spontaneously, you can basically treat this conservatively, but for the most part, because of how conservative we are in medicine, if there is some sort of vomiting up blood, significant amounts of blood, then you're probably going to want to get this person evaluated with endoscopy when you're concerned about bleeding. Because the bleeding, obviously they're vomiting up blood, but you don't know if it's just going to be passing through passively through the GI system, and then they're going to start to develop what? Melena as a result of the bleed. Gastritis. What is gastritis? Gastritis is inflammation of the stomach. Gastritis is a broad term that covers many causes that induce inflammation within the stomach. This can be erosive or non-erosive. What are some of the causes? So this is a moment for you to think through. Try and get as many as you can. What are some of the causes of gastritis? Some of the causes would be alcohol, spicy foods, NSAIDs. It could be a virus, a viral gastroenteritis. Think about that. Viral gastritis. Bacterial. What are some of the bacterial forms of gastritis? The one that you should pop up right up in your head should be H. pylori. TB can also cause gastritis. What is the workup of gastritis? CBC, CMP, lipase, pregnancy test, fecal blood, urea breath test, serum H. pylori, and consider endoscopy. So those are things that are all included depending on, obviously, the clinical presentation and what's going on. Treatment H. pylori is what? How do you treat H. pylori? This is a good time just to throw that in there to see what you can remember. The treatment is a PPI, levofloxacin, amoxicillin, or a PPI, bismuth, tetracycline, and metronidazole. So they have triple or quadruple antibiotic therapy. If the gastritis was caused by NSAIDs, then you might want to be considering a different medication to manage pain. You could use Celebrex, you could add a PPI. You may want to change dietary things if it's related to either alcohol or to eating too many spicy foods. If it's a virus, it's generally something that will pass on its own, and if it is bacterial, you're going to need to identify the bacterial agent causing it and treat it with antibiotics. What are some of the signs and symptoms in general of gastritis? Signs and symptoms include belching, dyspepsia, discomfort in the stomach, abdominal pain. Maybe they have nausea and vomiting and bloating. What's one of the main things you want to think of whenever anyone has gastritis is number one question is there bleeding? Are they vomiting up blood, or is there blood passing through the GI system? So that's why as part of the workup you may want to do a fecal occult test just to detect if there's anything mild to see if this is an erosive condition, because the main thing is an ulcer will bleed. Continuing with ulcers, remember there, so we're going to call this PUD. PUD stands for peptic ulcer disease. Peptic ulcer disease, what are the signs and symptoms of peptic ulcer disease? Abdominal pain. It's typically a burning pain. Dyspepsia. There, you can have ulcers in the gastric area or the duodenal area. How do you differentiate between those two? How do you differentiate between a gastric ulcer and a duodenal ulcer? Generally, as soon as you eat, things go into the stomach and you have pain after the meal. It's going to take some time for the stomach to empty, and then that acid, that acidity in the stomach is going to go into the duodenum, and that could be 2 to 3 hours after the meal. Often it may occur at night. So the timing can help you differentiate between a gastric or a duodenal ulcer, which is why a endoscopy can be very helpful in the diagnosis to see the location. As part of the workup, you're going to be considering a CBC. Why? Because you want to look for anemia. If they have this nausea and vomiting, you might as well just run the CMP. The individual, if you're considering H. pylori, you may want to do an H. pylori breath test or an IG blood test to detect H. pylori. I believe there's also a fecal test for H. pylori. You can look in their history and see if there's significant use of NSAIDs, and you may want to change that. They may have just this genetic condition. What is the genetic condition that causes a significant amount of increased acidity in the stomach? That is Zollinger-Ellison syndrome. So, going back to signs and symptoms, we mentioned abdominal pain. Typically, it's a burning pain. If it's right after you eat, it's gastric. If it's 2 to 3 hours after you eat, think of duodenal. But the main thing behind an ulcer is ulcers bleed. So they may be vomiting up blood, or there will be melena. Those are your two main symptoms that would indicate that there is peptic ulcer disease. Melena is black tarry stools. So endoscopy is going to be the definitive diagnosis of peptic ulcer disease. The treatment, if it's bleeding, you probably want to refer them to a GI specialist. The treatment tends to be just a PPI. The H. pylori is going to be quad therapy, bismuths, a PPI, tetracycline, and metronidazole. The triple antibiotic therapy, it used to be clarithromycin, a PPI, and amoxicillin. So if they have H. pylori, you'll be looking up what the most current treatment protocols for that. I believe it's now moved from triple antibiotic to quadruple therapy. There is another buzzword associated with peptic ulcer disease, and that is coffee ground emesis. Coffee ground emesis' buzzword is hematochezia. Hematochezia is coffee ground emesis and would make you be thinking of peptic ulcer disease. Look for comorbid anemia. The treatment is usually, if it's this non-ulcerative where it's not bleeding, a PPI for 12 weeks, 2 times a day. You could consider adding Maalox or Mylanta, and you could add sucralfate to help with this. That kind of helps protect the lining of the stomach, and they may need iron to treat the anemia. Moving onward, we have GERD. GERD is gastroesophageal reflux disease. Why is this significant? GERD, chronic symptoms of GERD can lead to what? Chronic symptoms of GERD can lead to Barrett's esophagitis. This is generally a precursor to esophageal cancer. What is occurring in Barrett's esophagitis? The general columnar epithelial is the general... Delete that last part. Barrett's esophagitis is the process where the cells change. Generally, the normal cells in the esophagus are going to be squamous to tall columnar epithelial. In Barrett's esophagus, the normal squamous epithelium of the esophagus becomes replaced with types of columnar cells that may predispose a person to an adenocarcinoma. So squamous epithelium are going to be converted into columnar cells. That shows up on tests all the time, but it's not always the thing that you're going to be thinking about in clinic. That's just more of the definition of what's going on. Signs and symptoms of reflux are heartburn, regurgitation. That reflux is, it's the acid squirting up all the way through the esophagus and lands in your mouth. You may have kind of a metallic taste. It can cause some dental erosion, even a sore throat, dysphagia. One of the things that is indicative of GERD as well, it's a cause of chronic cough. That's because as you're sleeping, you have the reflux. Basically what's happening is that acid's going up the esophagus, and it may actually fall back in and start to affect your lungs and drip into your lungs, and that causes a chronic cough. It can lead to an esophageal stricture. What is an esophageal stricture? That is because it's been eroding, and as a result of that, the esophagus is getting thinner and thinner and thinner, and that can cause dysphagia. So when you swallow, food can get caught there and it feels like you're choking. The diagnosis, you can diagnose this definitively with upper GI endoscopy, esophagogastroduodenoscopy, or esophageal manometry. The treatment of GERD, of reflux, tends to be some things you can do when they're sleeping is you can elevate the head of the bed. Losing weight can be helpful. making dietary changes such as avoiding alcohol, spicy food, and coffee. Also, you may want to wait about 3 hours after you eat to lie down. The most common treatments are going to be H2 receptors, that would be medicines like ranitidine, and PPIs. A common one of those is omeprazole, 20 milligrams once or twice a day. Antacids like Tums can also be helpful. So those are the initial treatments of GERD. You can mix and match depending on the severity of them, and there are a lot of different types of PPIs as well as H2 receptor blockers. One of the things that is on the black box of a PPI that's kind of a fun thing to know, PPI, chronic use of a PPI is going to affect your ability to digest food because acidity in the stomach is actually useful for digesting certain nutrients. And I believe that chronic use of omeprazole can cause an anemia because the acidity is useful in digesting iron. Transthoracic fundoplications is another thing that you can use to treat. Basically what they're going in is they may go in and tighten the muscle, the sphincter that goes in between the stomach and the esophagus, and that can be helpful. So there are some surgical treatments for GERD. Some of the foods that are associated, it's not just spicy foods, but other things that can cause gastritis, remember, are coffee, tea, caffeine, chocolate, fatty foods, and cheese. So most of the good stuff in life is going to end up biting you in the butt sooner or later. So I forgot to read this one earlier, but this is esophagitis. What is the most common cause of esophagitis? The most common type of esophagitis is candidal esophagitis, meaning it is somewhat secondary to thrush in the mouth. Risks of esophagitis, well, if you are having a candidal infection in your mouth or in the esophagus, then this individual is probably at risk of being immunocompromised and they may have HIV or have had some significant exposure. Signs and symptoms would be similar to GERD. They could have dysphagia or dyspepsia. The diagnosis would be generally through, if you can see it on physical exam, if they're seeing thrush in their mouth, it may be an indication that it's gone deeper. But if you're not seeing any signs in the mouth, the only way to identify it would basically be through an endoscopy. You could do a KOH prep. That's usually something to remember when they have thrush in the mouth. You would take a little scraping, put that under the microscope, and then do a KOH prep, and that will be helpful for the diagnosis of Candida, something you can do in office. The treatment, if it's related to Beckett's disease, steroids. If it's eosinophilic esophagitis, then allergies. But what is Beckett's disease? Beckett's disease is when you're basically getting tons and tons of ulcers in the mouth. Beckett's disease it would be this acute onset. It's like you're getting multiple canker sores or like herpes, because herpes is usually going to be just this cluster in one spot, whereas Beckett's is just kind of diffuse and everywhere. And if they have Beckett's esophagitis, then steroids would treat it. If it's eosinophilic, that is an eosinophilic esophagitis. I've seen that in life a couple times. One of my friends has this allergic reaction to corn, where if he eats corn, then the esophagus gets inflamed and it just tightens, and then he can't even eat. Nothing will pass through there until it clears. So anti-allergy medications, if it is a fungal esophagitis, then antifungals will be helpful. If it's herpes, then an antiviral or just watchful waiting. Remember that CMV, Epstein-Barr, can also cause esophagitis. And if it's related to reflux, then you're going to be treating with sucralfate, a PPI, or an H2 blocker. Pyloric stenosis. What is pyloric stenosis? Pyloric stenosis is, if the word stenosis is a narrowing of the pyloric sphincter, which is the connection in between the stomach and the small intestines. What is the cause of pyloric stenosis? Most of the time, the cause is unknown. It's considered to be genetic. At what age is pyloric stenosis mostly presenting and most relevant? It's typically a concern of infants in the first 2 to 6 weeks of life. What are the signs and symptoms that make you think of pyloric stenosis? The big buzzwords associated with pyloric stenosis are going to be projectile vomiting that is non-bilious, and the child is still hungry. How do you know when a child is hungry? They're extremely fussy, because kids are always spitting things up, but you can tell if the food is actually getting to them because they eventually calm down and they're not hungry anymore. Whereas this infant is going to be very, very uncomfortable. They're going to be very hungry. And whenever you try and give them food, they're going to just spit. When I've heard of projectile vomiting, I have a brother that I think had pyloric stenosis, and it was like shooting across the room. So it can be quite extreme, the degree. So projectile vomiting in an infant is going to make you think of pyloric stenosis. The other thing that they like to throw in on test questions is on the physical exam, if you're feeling in that area, you may be able to feel a mass. They describe it as an olive-sized mass. And so an olive-sized mass may be indicative of pyloric stenosis. Again, these are very young infants that this is occurring. The concerns are, obviously, if the child is not eating, then they can develop signs of dehydration and malnutrition, and this needs to be treated emergently. An X-ray and an ultrasound, you could run an X-ray, but the ultrasound is diagnostic. On an ultrasound, you may see the pyloric muscle greater than 3 millimeters. At that point, so if you are considering that this is pyloric stenosis, you're going to send the infant to get an ultrasound. The ultrasound will be able to rule this in or out. And if it is pyloric stenosis, then they're going to need a surgery. The last things that we have are foreign body ingestion and food allergies. So foreign body ingestion is, what do you usually do with a foreign body ingestion? The treatment tends to be usually observation. It could be surgical, though, depending on what is swallowed. The thing that they love to throw at you in tests are, what is the thing that would require surgery? And that would be if they have swallowed magnets, is what I wrote, but I don't know if I also meant to write that they have swallowed batteries. If they have swallowed batteries, something that could be poisonous, then that is more of an emergency and they need surgery. But a lot of times the things that people are swallowing, little kids are swallowing coins or other pieces of metal. I think someone swallowed a pin once and they just watched and observed it, coin. And you can do that by doing serial radiography, just continually looking at it. If the child is showing symptoms, and what is the sign and symptom of some sort of ingestion? Either the kid is acting weird, so they may have just the history of swallowing something. Most of the time the parent will catch them, or the kid will say, I swallowed this and I feel weird. So that history is the most significant thing. If it's, sometimes this may also not just be something that you run into as gastrointestinal. If they swallowed something that may be caught in the upper respiratory, and that can be seen as well. If it's not radiopaque, then you're going to need to be doing a CT scan sometimes. So the risks, abrasions, the risks that come from foreign body ingestion are going to be that you could have abrasion in the GI tract, a puncture or a laceration, or it could be a toxic thing if they've swallowed something that potentially contains a toxic material, such as batteries. If there's upper GI obstruction, then what's happening, very similar to allergic esophagitis, the patient would not be swallowing and they may be drooling. But they are breathing, so the obstruction is not in the airway, it is in the GI. And so that might be another indication for some sort of procedure to remove the foreign body. Again, most of the time, the treatment is going to be observation. Ingestion of a caustic substance or an intentional overdose. So this is going to be an opportunity to review your antidotes. So what are the signs and symptoms? It could be very broad depending on the amount that has been ingested. The patient may present to you completely unconscious. They may have Dyspnea, dysphagia, chest pain, abdominal pain, nausea and vomiting. This could be severe, very similar to this extreme nausea, extreme vomiting, painful. If the patient is conscious, they may be able to tell you what's going on. They may present telling you that they had just taken a bunch of acetaminophen or benzos or opiates, that they tried to overdose on some of these things. If not, then you're going to be running a drug toxicology to identify what this could be. And once you've identified what it is, or perhaps a lot of times the person bringing them into the hospital or the emergency room is going to be telling you, oh, we found a bottle of this, or this patient takes this medication, or we had this lying around. So those clues are going to be helpful in the history. Generally, what are the treatments? You may do an NG tube to suck out the stomach. Epicac is not used anymore to barf it out. NG tube is really the gold standard, that gastric lavage. Activated charcoal can be good sometimes, 50 to 100 milligrams, and that can be useful in carbamazepine, dapazone, phenobarbital, quinine, and theophylline. So what is the number one priority when you have ingestion of a caustic substance or an intentional overdose? The number one priority is 1, airway. Make sure that the airway is maintained. And number 2 is to get rid of the caustic substance, so that would be that gastric lavage. And you're going to be looking at your antidotes. So calcium is an antidote to what? Calcium channel blockers, overdose. Glucagon is an antidote to what? Beta blockers. Bicarbonate is an antidote to what? A tricyclic antidepressant. Ethanol is an antidote to methanol. Physostigmine is an antidote to anticholinergics. Some of the main ones that you're going to want to know, though, are acetylcysteine is the antidote to acetaminophen. Flumazenil is the antidote to benzodiazepine. And Narcan is the antidote to opiates. The only ones that I did not list were deferoxamine can be the antidote to an iron overdose, and digoxin immune OV is for digoxin. So that is your intentional overdose. A lot of that would just be some basic memorization. The main 3 I know are acetylcysteine for acetaminophen, flumazenil for benzos, Narcan for opiates, and then anything else that you have off the top of your head just makes you an all-star. So, food allergies. What is the most common food allergy that we talk about? The inability to digest lactose. 25% of whites, 75% of the world has some difficulty digesting lactose. I know that there are breeding cows that they genetically modified that will not make lactose milk, which is kind of interesting. If there's lactose intolerance, what's one of the concerns behind lactose intolerance? It may lead to osteopenia, since a lot of people get their calcium through milk. It mimics irritable bowel syndrome. So what are the signs and symptoms of a food allergy, such as lactose intolerance? It could be you're just kind of bloated and come and go, mild abdominal pain. You may also have diarrhea, loose stools, pain, flatulence is a common one. Borborygmi. What is borborygmi? Borborygmi is when your bowels are screaming. It's what happens when you're on a date for too long. Nausea could also be a concern. So what they did say is that 44% gain the ability during, let's just delete that last part. Diagnosis of lactose intolerance is a milk tolerance test, 500 milliliters, and then test the blood glucose. Hydrogen breath test can also be helpful. Lactaid is one of the treatments, supplemental calcium, and just, again, stop the offending agent is always the primary treatment when it comes to a food allergy. Signs and symptoms. If it was a significant food allergy, the individual may present with anaphylaxis, angioedema, stridor, wheezing, laryngeal edema, and urticaria. So Those are the most significant ones. Obviously, if an individual presented with anaphylaxis and they're having difficulty breathing, this is going to be going to the emergency room where you're going to be working on maintaining the airway. Most of the time in a general medicine, a patient is presenting with a rash, and that could be hives such as urticaria. Which is urticaria, that is. The workup, what is the workup if you're trying to find allergies? Because you can try and do the Sherlock Holmes and identify, okay, was there anything new in your diet, anything new, a new exposure, and that's a good place to start. The most definitive way that they do this is going to be a skin prick test. A lot of times that's done at an allergist specialist. Prick testing is the standard. There's IgE antibodies can confirm that that this is an allergic reaction, IgE antibody, and most of the time the treatment is avoidance. Now, last but certainly not least, I should have put this in when we were talking about celiac disease, but here we are, celiac disease. What is celiac disease? Celiac disease is gluten insensitivity. What is gluten found in? Gluten is found in all sorts of things. They actually just package it in all sorts of weird things, like even lunch meats. But it's most commonly found as a product of wheat, rye, and barley. The signs and symptoms are going to be similar to lactose intolerance. They can be similar to irritable bowel syndrome. And those symptoms are basically diarrhea, gas, borborygmus, weight loss, weakness, fatigue, abdominal pain. They may be at risk for some malabsorption problems. What is the diagnostic? So these are the tests that you need to know that are associated with celiac disease. They are what? IgA, TTG, tissue transglutaminase. The workup, generally you're going to be doing, this is part of a broader workup when you're trying to identify what it is, but if you're thinking just specifically for testing purposes what tests are associated with celiac disease, think of the TTG, tissue transglutaminase, or an IgA. The diagnostic, though, this is where people love to trick you because that's what you do in real life to test, because not many people actually go through the definitive diagnosis of celiac disease, which is what? That would be a biopsy with histology. Treatment, make sure that the patient is getting enough vitamin D. They will be needing to avoid gluten. So a gluten-free diet is the treatment, and that is the end of the gastrointestinal system.